I'm Dr. Karen Anderson. I'm the director of the Huntington's Disease Care, Education, and Research Center at MedStar Georgetown University Hospital. We see people from the DC metro area, from Virginia, from Maryland, who have Huntington's disease in their families or have been diagnosed with Huntington's disease. We offer a truly multidisciplinary approach to Huntington's disease care. Huntington's disease is a very complicated illness. It has psychiatric symptoms, neurological symptoms, and memory effects. So we have a team comprised of neuropsychiatrists like myself, another neuropsychiatrist, several neurologists. We have a neuropsychologist who does extensive memory testing. We have genetic counselors, and we have a social worker who provides comprehensive care and assistance with patients in obtaining benefits and extra care at home. We see people who've grown up knowing that there's Huntington's in their family and they want to find out if they're going to develop the condition, so they may come in for genetic testing. And we see people who've been diagnosed elsewhere and are looking for specialized care. Huntington's disease research has been going on for many years, but really in the last 5 years, the clinical trials have been taking off. And it's true that there's no cure, but there's so much that can be done to make the condition easier for people who have it and for their families. In some ways, Huntington's is kind of like cancer was many years ago, where people wouldn't talk about it and they would hide it if it was in their families. And I think we're working really hard to change that now. Because it's a genetic condition that's very strongly inherited, every person who has a parent with Huntington's disease has a 50% risk of having Huntington's disease. That means I get to know families over a span of many years, and I get to work with them as they come to terms with how the disease affects their family in the long term. I think people would choose to come to MedStar Georgetown because we have such a multidisciplinary approach. We provide so much care in one visit. We're able to tailor care very individually to patients and families, and we provide access to world-class research. These are all things that people can't get at one stop elsewhere in the region. Our center offers very streamlined care. Someone can come in and literally see 5 or 6 different specialists in the same day. They can also find out about new research developments in the same day. They can get a lot of things done in one appointment. There's so much need in families who have Huntington's disease. There's just so much that can be done. And as I said, there was a perception for a long time that it was a hopeless condition. And I really want to work to change that. Huntington's disease is a genetic condition, which means that it's inherited. Unlike a lot of other genetic conditions where there may be some small risk in the family if you have a parent with a condition, Huntington's disease is autosomal dominantly inherited. That means if you have a parent with Huntington's disease, you have a 50% chance of developing the condition. Huntington's disease also has a lot of different symptoms. It has behavioral symptoms like depression, anxiety, and sleep issues. It has neurological symptoms like fast movements called chorea, balance and swallowing difficulty, speech difficulty, and it has memory difficulty. So people have difficulty organizing things, getting through a multi-step process, and learning new things sometimes. The symptoms can certainly be treated in some cases very well. The psychiatric symptoms like depression, anxiety, sleep issues can all be treated with the medications that we have available now. Some of the neurological symptoms like the rapid movements can be treated, and certainly we can test memory problems to see which are amenable to treatment and which are ones that might prevent someone from working so that they have a better handle on when they might want to stop working. Often out in the community, there are people who provide excellent care, but the difficulty families run into is coordinating the care. They may have an excellent social worker in one location, they may have a psychiatrist in another, a neurologist in another, and a physical therapist elsewhere. And it's very rare for all of these specialists to be able to communicate with one another and formulate a team approach to care for such a complicated condition. The typical age of onset for Huntington's disease is between 20 and 40. but certainly there are many exceptions to that rule. People have been diagnosed as young as age 2, and we've certainly had people diagnosed in their 70s and 80s. The diagnosis is made when somebody goes to a neurologist or neuropsychiatrist, has an examination, and finds out that they have a certain level of movement symptoms, usually the fast movements like chorea, but also the balance difficulties, changes in eye movements that look like Huntington's disease. If there's known Huntington's in the family, that's often enough to make a diagnosis. If there's a question about whether there's Huntington's in the family, a genetic test might be done at that time too. So that's symptomatic diagnosis for somebody who's developed some sign that they have Huntington's disease. There's also what's called pre-symptomatic testing, which is when someone knows there's Huntington's in the family and they want to find out if they have the genetic expansion that causes Huntington's disease. In that case, they'll come in and they'll have blood drawn, and after counseling and some very careful consideration, the result will come back and they'll find out if they have the expansion or not. If they don't have the expansion, there's no chance that they'll have Huntington's, there's no chance they'll pass it on. If they have the expansion, it means at some point in their life they will develop the condition, but it's very hard to predict when. At MedStar Georgetown, we have a team approach to genetic testing. We have excellent genetic counselors. We also provide psychological and psychiatric evaluation and other support for people who are thinking about testing. We really want it to be a process. When people come in for the first visit, it's certainly not a given that they're going to get the genetic testing done. We like to guide them through thinking about what the implications are for themselves, for their kids, for others in their family, if they should test positive or negative for the Huntington's gene expansion. Because Huntington's disease has been associated with a lot of shame and secrecy, in some families, the older generations may know that there's Huntington's disease and they may have concealed it from their children. We've unfortunately had situations where people have found out the night before they've gotten married that there's Huntington's in their family, or they found out when they've gotten pregnant that they're at risk for Huntington's disease. So it's not always a known factor, and that can make the diagnosis very challenging if the family history is hidden. If you're at risk for Huntington's disease, if you come for a family where you know that one of your parents had Huntington's, it's worth thinking about getting testing, but testing is not for everyone. Not everyone wants to know if they have an expansion that could cause a disease with many complicated symptoms at some point in their lives, because testing doesn't really tell you when you'll develop the condition. If you yourself have Huntington's disease, the risk is 50% for each child. And the important thing is to think of that as flipping a coin for each child. So if you have 4 children, if 2 of them have Huntington's disease, it doesn't mean the other 2 aren't going to get it. It's a 50% risk for each child. So it's like you're flipping a coin, heads or tails, for each of the children. Some people with Huntington's find they have difficulty with motivation. They have difficulty getting up and doing the things that they like to do. Many people will find that their hobbies just aren't as interesting. We've had people who like fishing who find they just can't get themselves to go out and fish, for example. Sometimes the motivation problems become more severe to the point where, unless somebody prompts them, patients will literally stay in bed in their pajamas all day and eat cold cereal because they just don't have the desire to get up and do things and take care of themselves. Part of the memory difficulty that people with Huntington's have is difficulty with sequencing and difficulty with switching between things. So the memory problems in Huntington's are very different than Alzheimer's. It's not really difficulty with learning new information, at least not early on. What people find is that anything where they have to go through a series of steps, or if they have to switch back and forth between things, if they have to multitask, it becomes really challenging even early on. One of the symptoms of Huntington's disease that we're starting to learn more about is sleep disturbance. People with Huntington's disease have several different reasons for having sleep trouble. The fast movements that I've talked about, the chorea, where people move about and they often look like they're anxious or fidgety, keep some people from falling asleep. If someone wakes up during the night and the fast movements start, that will often prevent them from falling back to sleep. Once they're asleep, of course, the movements do stop. There are other reasons for sleep difficulty in Huntington's. Some people have severe depression, which can interfere with sleep. Some people aren't working, they're off schedule, so they can sleep during the day and then they find they're up all night on the computer or watching movies. And people with Huntington's tend to reverse their circadian rhythms, so many of them do stay up a lot at night and sleep during the day. One of the other things that can develop even very early on before the neurological symptoms are the emotional symptoms, and one of the really prominent ones is irritability. So many people, long before they develop movements, find that they constantly feel annoyed by things that shouldn't bother them, cause them to have outbursts. They find that they're yelling or throwing things over very small matters, or their families may notice this before they do. They may notice that the person's personality has really changed and they're no longer tolerant of noise or family things that used to be just fine. It's very hard to predict based on what someone's parent had, what type of symptoms they'll develop. So for example, if you have a parent who had Huntington's disease and had severe choking problems, maybe earlier on in the illness, it's very, very hard to predict whether you yourself will develop choking problems at a certain point. Most people who have Huntington's disease do have difficulty with eating and do have some choking at some point, but it's very, very hard to predict when that will happen and how, what form it will take in an individual. In terms of treating choking, an evaluation by a speech therapist is very helpful. A speech and swallowing therapist evaluation is very helpful. They can make recommendations in modifying the type of food someone eats. They can show them particular tricks to do while they're eating, often encouraging someone to slow down, to sit at a table, not eat standing up, not grab things on the go. That can help a lot with the choking issues. One of the difficulties with Huntington's disease is that you can't predict when someone's going to get it. So if someone gets tested and they have the HD expansion, they get back what's called a CAG repeat number. So for example, they may have a repeat number of 40. So one question we're often asked is, if my mother developed Huntington's disease and she had a repeat number of 40, if I have the same repeat number, am I going to develop Huntington's disease at the same age? And the answer is we don't know. People can certainly have a 10 or 15-year difference in the time of onset of symptoms when they develop symptoms compared to other family members, even if they have the same CAG repeat length. We often see something called anticipation in Huntington's disease. So that means that if a father transmits the HD expansion, it will often become a bit larger in the next generation. And sometimes that will cause earlier onset of symptoms. Not always, but that is something that you can see with anticipation. At this time, there's not a cure for Huntington's disease. There are several different agents that are being tried right now. They are developing agents that they hope will turn off the Huntington's gene so that it doesn't make abnormal protein. They're developing agents that they hope will protect the brain cells so that the Huntington's protein doesn't cause damage. They're working on several different angles to treat it. At this time, there's nothing that's approved for treatment of Huntington's disease in terms of slowing the disease progression. However, there are great treatments for many of the symptoms. Physical therapy evaluation and treatment can certainly help with balance and walking issues. The speech and swallowing evaluations can help with choking and communication issues. And certainly we have great psychiatric medicines to treat many of the emotional symptoms. The movements can be treated with some of the neurological medications. From the time that someone's diagnosed with Huntington's disease, they'll usually live for 10 or 15 years with the condition. That varies a lot though because people are diagnosed at different points, and of course if someone's receiving excellent care, they will often live much longer with the condition. I think it's really important for people with Huntington's disease to participate in clinical trials if they're able. The only way that we're going to find a cure for this condition is by people trying these medications. We have great animal studies, but animals aren't people, and animals will never tell us what works in people. Here at the MedStar Georgetown Center, we have clinical trials to treat symptoms of Huntington's disease, and in the future we'll have clinical trials to slow down the disease progression. We also have what are called observational trials. This means that you come into a study and we look at how your symptoms change over time. These are very important because unless we know more about how Huntington's develops and how it changes over time, we won't know if we're developing the right treatments for it. Observational studies are so important in Huntington's disease. Even though we've known about this condition for a long time, it's a rare disorder. So unless we can really measure things in people, measure how memory changes, measure how emotional symptoms change, look at the neurological symptoms very carefully over time, we really won't know if we've developed the right treatments for the right people. We know from historical documents that Huntington's disease has been prevalent at least since the 1400s, probably 1600s. There are descriptions of conditions like St. Vitus dance, where people had rapid movements and emotional symptoms going back, several hundred years. Huntington's disease itself was described by a physician named George Huntington. This was in 1872 in the New York area, where he observed numerous families. And really, he was able to describe the condition because he'd worked as a physician with his father and grandfather in the area, and he recognized that there was an inherited condition in several of the families in the community where he worked. Huntington's disease is always an inherited condition, meaning that there's a genetic expansion that occurs that is gotten from one parent or the other. There are cases of families where it's not known to be in the family. So for example, if someone has a smaller version of the genetic expansion, it might not be evident in the first generation, but the next generation might get a slightly larger expansion, and then the symptoms will show up. Even though we've known the gene for Huntington's for several years now, and we know that there's an abnormal protein called the Huntington protein, we don't actually know what the process is in the brain that leads to all these symptoms. We know that there's an abnormal protein produced, and we know that it tends to clump up into these bunches called aggregates, but it's not entirely clear how this leads to all of the emotional, neurological, and cognitive symptoms that we see in our patients. When you have a rare condition like Huntington's disease in the family, you want to see people who know the condition and know what they're treating. Many excellent physicians are trained in neurology but only see 1 or 2 cases of Huntington's the entire time of their training. There are other specialists who never see people with Huntington's disease. At MedStar Georgetown University Hospital, we have a team that sees hundreds of people with this condition and is very current on the research. That's the kind of care you want to look for when you have a condition like this in your family. Based on data that's a bit old, we think there are about 1,500 in the DC metro area, 1,500 people who have symptoms of Huntington's disease. Looking out farther into Virginia, Maryland, and DC combined, there are probably about 8,000 or 9,000 people who are at risk for Huntington's disease. Again, this is based on old numbers. We haven't really looked at the population carefully in many years. Based on data from many years ago, it's estimated there are 30,000 people in the United States who are affected by Huntington's disease, who have the diagnosis, and another 150,000 who are living at risk from the condition. I think those numbers are very low. The population has grown greatly since those estimates were made. Huntington's disease is more prevalent in Caucasian populations. There are certainly clusters of isolated villages, for example, in South America, where villages are isolated in the mountains, where there's a very, very high prevalence of Huntington's disease because people tended to intermarry between families, so the gene would be transmitted frequently. In places like Africa and China, we think that it's probably a lower prevalence, although the studies really haven't been done. So it's really hard to know in many ways how prevalent it is in other parts of the world. At our center, when we give someone the diagnosis of Huntington's disease, we know that this has far-reaching impact not only for them but for other members in their family who may now find out that they're at risk. We take a very careful team approach. We provide a lot of support, and we provide the most important thing, which is information, so that people understand what this means, they understand what can be treated and what can't at this time, and they understand that the research is coming, so that in a few years we will have very effective treatments for this condition. Because HD is a genetic condition, but it's autosomal dominant, that means that it's actually inherited equally in men and women. So there's no increased or decreased risk depending on whether you're male or female. It's 50-50. There is a rare form of Huntington's disease called juvenile onset Huntington's disease, which is onset of symptoms before age 18. It's associated with a much longer CAG repeat. So a typical CAG repeat that we see in adults is maybe a 40 or a 45. People with juvenile onset have been reported to have 80 or even 120 repeats in their CAG repeats. Juvenile onset HD has a different picture than adult onset HD. So rather than the fast movements called chorea, they tend to have more dystonia, which is posturing and positioning of their muscles. They have seizures sometimes, and they have a very rapid progression with very rapid loss of their cognitive abilities. So you might see a child who's performing fairly normally in school who within a few years cannot even attend school, cannot really learn. People with juvenile onset HD usually have a much shorter survival time. So it's often more like 7 or 10 years rather than 10 or 15 years. I think one of the most challenging symptoms in HD is severe depression. About half the people who have Huntington's disease will develop depression at some point in the condition, and it's often treated very effectively with antidepressant medication. But for people who don't respond well to antidepressants or who choose not to be treated or aren't seen for treatment, the depression can become very severe. And one of the things that we worry about in people with Huntington's disease is suicide. They do tend to have a rate of suicide about 4 times that in the general population. And because there's a lot of impulsivity associated with Huntington's disease, people who try to kill themselves who have Huntington's use very lethal methods. So they'll often use a gun or jump off a bridge or something else that's very final. If someone has severe depression, it's very important that they get evaluation and treatment. As a physician, I have a very low threshold for hospitalizing someone who's very depressed with Huntington's disease because, again, I worry about this risk that they'll try to harm themselves. I think part of what makes Huntington's disease such a difficult and challenging illness is not the neurological symptoms, it's not the loss of balance, it's not the movements, it's that it takes away something of the person that someone is. Really, their personality changes, their appreciation for things changes, their interest and involvement with the family is often decreased, and it really erases a lot of what makes someone a person in many cases. And I think that's what makes it such a tragic and difficult illness for so many families. When I first started working with Huntington's patients and families, I realized that it was a condition where so much could be done, where so much good could be done. It's rare in medicine to find a condition where there's so much need and where there's been so much secrecy and lack of treatment for so long. And I think that was one of the things that really attracted me to Huntington's disease. The other part of it was that I really like as working as part of a team and part of a multidisciplinary team. And I've realized very early on that to care for people with Huntington's disease, you really have to have a team.